Hi everyone, welcome. We're just going to wait a moment or two to let everybody in. I'm Marina, I'm the Programming Director at Emanuel Synagogue, and welcome. How exciting today to our health talk. We've got Dr. Jenny Mansberg and Rabbi Jacqueline Nino. So welcome everyone. Before we start, as I said, while we're waiting for a few more people to come on, please check out our website, have a look at our website. We've got a great event coming up at the end of the month, celebrating 80 years of the Danera voice, and it's Danera Tatura and Leonard Adam. We're showcasing a wonderful artist from that period. August the 30th, please check out our website, and I look forward to seeing you all again then. And I'll hand it now over. So people are slowly coming on, but I'll hand it over to you, Rabbi Nino.
Thank you. We want to begin with an acknowledgement of the traditional custodians of the land upon whose land we now live and work, the Gadigal clan of the Eora Nation. We walk with respect on the land that sustains the spirit of these people, and we acknowledge the vital contribution that Indigenous people and cultures have made to the nation that we share, Australia, and we walk with respect towards the future. We are thrilled this morning. I am especially thrilled to welcome Dr. Jenny Mansberg to our Health Conversation series. Jenny has been a GP for 30 years, specialising in the areas of women's health and children's health. She is the author of 3 books, countless articles, and is a sought-after speaker and authority on everything from sleep and wellness, life balance to stress. Ginny is the host of SBS's 8-part show Medicine or Myth and Foxtel's Embarrassing Bodies Down Under, as well as being seen regularly on our screens, guiding us as the resident GP on Channel 7 Sunrise and The Morning Show. Ginny has a remarkable gift for being able to explain the medicine and the science, the research and the statistics in an engaging way, which enables us all to understand the issues. She's knowledgeable, incredibly intelligent, a remarkable and beautiful human being who is able to make people feel heard and understood, and to guide us to the best outcomes for our health and well-being. Ginny is mother to a blended family of 6 and lives and works in Sydney, and is a proud member of Emanuel Synagogue. So Ginny, we welcome you today, and we are so grateful for your time in the midst of an incredibly hectic moment in your life, as well as this uncertain world in which we are living. The session today came about because from the time we set up these health discussions, I was plotting to bring Ginny in, but I wasn't sure exactly what the topic would be. And then I heard her in conversation with Mia Friedman about her newest book, The M Word. This is it here. Oh, we both have copies. Excellent. Discussing menopause. And I had been waiting for this book, and I was so thrilled that it was manifest and came into existence through Ginny. And I immediately wrote to Ginny and Mia, thanking them for the segment and for talking about this issue. And I called Marina to organise for Ginny to come and speak to us. So I am so grateful that you're here, and I'm so grateful that we have the opportunity to have this discussion. I believe, as Ginny, you have said, that menopause is such a taboo subject, and at the same time there is too much and not enough information. So today we're going to talk all things menopause, try and debunk some myths, open our eyes perhaps to some aspects of menopause that we hadn't associated together with this time in our lives, and answer as many questions as we can in the time that we have. Many of us, I want to reassure everyone that your questions will be anonymous, so please feel free to, don't be shy, just ask anything you want, and Ginny will be delighted to answer all those questions. We've also been very lucky to have 3 copies of Ginny's book, The M Word. So if you write your questions in the Q&A section at the bottom of your screen, then they will be anonymous. The only people who will be able to see who the questions come from, or any of the questions, will be me and Ginny as the panelists. So if you write them in the chat, I think other people might be able to see as well. So anonymous questions in the Q&A. We're very, very lucky. We have 3 copies of Ginny's book to give away. We're going to give one to the first person who registered today, and the other 2 copies will go to people who've asked questions. We won't announce who you are, but we will contact you afterwards and let you know that you have been the recipient of this wonderful wonderful book. So please ask questions along the way whenever they come up for you, and we'll try and answer them as we go. So enough from me, Ginny. Welcome. And if we could start with why you decided to write this book in the first place. What inspired this?
So if I'm going to be 100% honest, the publisher came up to me and said, we need a book on menopause, will you write one? And I had been really burnt by the last couple of books that I'd written, which I did not enjoy the process. And I actually had said, that's it, I'm never writing another book again, it's not worth it. But I just fell in love with the publisher. She's just such a cool chick. And when I started thinking about the fact that this was a really taboo subject, and it was in the middle of a few things happening at the same time. So I'm a GP. I graduated from medicine and into general practice around the time of the study that I'm sure going to talk a lot about, which is the Women's Health Initiative study that basically kicked all study of and treatments for menopause to the curb. Women were told to suck it up, and I learned nothing about it. So I felt really ill-equipped to meet the needs of my older patients. When I was a younger GP, I was seeing a lot of young mums like me, but you know, I am in my 50s now, so I was going to be seeing women who are older, and I felt really ill-equipped. And I'm also the host of an educational podcast for doctors, and it's called Drive Time Medical, and it's really to help GPs get across various subjects. And I kept interviewing experts in menopause, and every time I'd be doing these interviews going, I have no idea about this. I have no clue, and I need to know about it. And it's not taught. And so I went and joined the Australian Menopause Society, started doing, you know, a lot of online courses, getting credits for those. And then Corinne came to me and said, I think you'd be perfect for this book. I'm like, really? You think I look menopausal? Okay. But I did it, and I liked it so much I signed up for the next two books, which is hilarious. But yes, we're here to talk about this one now.
Well, we can talk about the others at the end. You can do a little teaser for what's coming and what we can
do.
So I think there's a lot of misunderstanding, and definitely for me, about terms that people throw around. So I don't really understand the difference between perimenopause and menopause, and maybe also just to look a little bit at some other words that are going to come up a lot: estrogen, progesterone, testosterone. Like, what are these things, and how do we even define what menopause is?
So menopause has a very specific diagnosis. It is 12 months since the first day of your last normal period. So let's say you were getting periods every sort of 3 months, every 6 months. When you had that very last one, you know, if you get to 9 months later and you have another one, we reset the clock, and it was since your last period, 12 months from then, that's the day. So you can open your champagne, that's the day it happens. However, if you've had a hysterectomy and you've got absolutely no idea, or if you're like me, I've still got a Marina in, which is an IUD that contains progesterone, so I wouldn't have a clue when it's happening. So that's, it's not always that easy. We can actually diagnose it with a blood test as well. Perimenopause is the period of time that leads up to menopause, and it's an average of about 7 years when hormones start to change. I know, look at your face.
7 years.
I know. And it is really hormone hell. I mean, you know, at least on the other side of menopause, everything kind of flatlines and you don't get these wild escalations of hormones. But in the lead up to menopause, you know, we got skyrocketing levels of anxiety and depression, like 1 in 3 women in that time, and that's regardless of whether you've ever had any mental health conditions. Just experience some severe symptoms of mental health symptoms around perimenopause. Your periods go crazy. You can get hot flushes as well. 1 in 4 women, you know, get hot flushes around that time. You can get aches and pains, all the other symptoms, vaginal symptoms, and yet you're still having your periods. And a lot of women want a blood test to diagnose perimenopause. And the problem is that within a single 24-hour period, your hormones are all over the place. What I will find at a blood test at 10 o'clock might be completely different by 2 o'clock. And it'll certainly be different tomorrow, and it won't tell us anything anyway. All I can tell you is that your estrogen levels are too high to technically be called menopause. And other than that, your tests are unreadable. So what does that mean? It just means it sucks, and it's really much harder to treat around that time. In terms of the hormones, estrogen's a big one. So the lack of estrogen is what causes a lot of the symptoms after menopause. Progesterone, I call it the chill out hormone. I call it kind of your Byron Bay to estrogen's New York City. So you know, if you've got plenty of estrogen on board, your brain's like, no, let's go. And progesterone's a chill out hormone. You only get progesterone if you ovulate. If you don't ovulate, you will not make progesterone. And your ovaries, you know, continue to make a bit of estrogen. They spit it out here and there, not very organized. But unless you have a nice ovulation, which disappears and is a bit more sporadic years before you actually go into menopause, you'll have an imbalance between your estrogen and progesterone. And not always low progesterone and high estrogen. It can be, you know, the other way around. If you do have an ovulation, you can make massive amounts of progesterone as well. And that's why every day is different. Your testosterone wanes in a very different way that has nothing to do with menopause. So your ovaries do make a little bit of testosterone, but a lot of it comes out of your adrenal glands, and they're on their own trajectory. They certainly, when it comes to puberty, they start activating much earlier than your ovaries, and they seem to die a lot later than your ovaries as well. And so it's very interesting. That's why you get a lot of chin hair.
Oh, we're
yes,
going to talk about that.
There is chin hair there. We don't need to discuss it. Stay anonymous. It's all good.
I want to talk about that too in a minute. So let's talk about the big issue around, I think, menopause. When people think menopause, they think hormone replacement therapy. And for many of us, the immediate link is it's dangerous and it will give us cancer. So
yeah,
tell us about hormone replacement therapy and why we have that link.
So most of the problems that happen from perimenopause and menopause happen from an imbalance of hormones, and specifically low estrogen. And in perimenopause, that will be cycling low, and after menopause, it will be always low. But regardless, the thought behind supplementing your body with estrogen that it's missing is because the symptoms mostly come from that lack of estrogen. So estrogen's the thing that we need. The problem is that if you have a uterus, in other words, if you haven't had a hysterectomy, and you give somebody estrogen, you don't give them progesterone, very high chance of giving them uterus cancer. So we have to give you progesterone as well, and that's called combination HRT. That's super good. So for symptoms like hot flushes that 75% of women get, it's sort of 96% effective at getting rid of those hot flushes. So it's super good. The problem came, so we had this sort of build-up of HRT when it was invented. People just went, this stuff is the elixir of youth. Look at my skin, you know, look at my vagina, it's so healthy. I just feel terrific on it. It's literally the elixir of youth. There were American doctors who literally said, the day you go into menopause, take this, no matter what your symptoms are, just take it, you'll feel great. And they made some fairly misogynistic comments that made a lot in the feminist community reasonably get their back up and just go, whoa, what are you saying? I mean, you can go through menopause and be still very womanly and feminine. What do you know? We don't dry out like an old hag here. But there were some fairly misogynistic things that were happening in the US, particularly in the 80s and 90s. And there was a massive study called the Women's Health Initiative Study, which is actually a brilliant, brilliant study. It is huge. It has a couple 100,000 women, and they were randomized. So nobody knew who were running the study who got hormone replacement therapy and who got a placebo. They used a fairly old form of HRT that we don't use anymore, and then they followed them up to see what happened to them. And there was a subset of these women who were overweight and who 6.5 years roughly after they'd started on their HRT, they were statistically significantly more likely to get breast cancer, and not by a lot. It was by a very small increase, but they were more likely to get breast cancer if they had combination HRT, so estrogen and progesterone. If you looked at the women who just got estrogen because they didn't have a uterus, didn't need progesterone, they actually had a lower risk of breast cancer, but there was that group that had this particular form of estrogen and progesterone. The study was halted early because they found that link, and they called off the study and made some fairly massive claims and some fairly sensationalist press releases that saw literally 80% of women who were at that time taking HRT throw it in the bin and say, I would rather have hot flushes, I would rather not sleep, I would rather have aches and pains, I'm happy to say goodbye to my sex life, that's fine, because I don't want to get breast cancer. And in fact, the risk was overplayed, and even though every menopause society in the world came out and saying, hey, it's actually not a particularly big risk, and we don't use that form of HRT anymore, the damage was done. And what we saw was drug companies saying, I'm not getting involved in that space, because Roche, who made the particular form of HRT that was in that particular study, got sued. There were $300 million worth of lawsuits against HRT companies. They rolled down the shutters on their women's health divisions. It wasn't taught to women anymore. It wasn't taught to doctors anymore. Doctors refused to prescribe it. And we are where we are today, where if a lot of women will go to their doctor and say, I'm having hot flushes, there's a chance that their doctor is going to say, that's just part of getting older. You're going to have to suck it up, princess. There's nothing we can do. And it's devastating for women.
So today, if people are given HRT today, it's very different from the one even that the study was involved. Yeah. Is that correct? And
correct. So it's given, we give a lower, there's no point taking estrogen if you can take it in a dose that's so low that it's not going to actually relieve any of your hot flushes. I mean, if you go down from 20 debilitating hot flushes a day to 15, I'm not calling that a win. I don't think if you're going to take estrogen, take it at a dose where you're not going to have any hot flushes. So we don't give you a homeopathic dose, but we give you a smaller dose of estrogen, but it's mainly the progesterone that has changed now. So the form of progesterone that they used in the Women's Health Initiative study was called hydroxyprogesterone acetate. It's actually still available. It's kind of crazy. And I sometimes see older gynecologists prescribing it, which is interesting. I wouldn't prescribe it. I think it's too high risk. There are newer forms now, and there are very low risk forms. There are studies that are ongoing for some of the forms of progesterone that we're using now that it really doesn't look like there's any increase in breast cancer, not even, 1 in 1,000. It's really, they're very low risk forms of progesterone now. And the estrogen dose is certainly much lower. We know that the women who got the HRT, even though in theory they were randomized in this massive study, they were the older women. They were women who are more likely to be fat, and overweight and obesity is definitely a high risk for breast cancer anyway. And so they had kind of the cards a bit stacked against them anyway. We now say that unless you have started your HRT within 6 years of menopause, probably, you'd want to be debilitated by your hot flushes before we start it, because the risk does go up. But if you start it around the time of menopause and just continue it until your hot flushes have gone, the risk is very low.
So we've had a couple of questions, and a few of them are related, I guess, to this HRT. So someone asked about the link between estrogen and bone strength, and whether HRT is something that will address that, and is it something that can be used for osteoporosis?
Yeah, it's actually, so what a great question, and thanks for bringing that up. Yeah, so estrogen absolutely strengthens bones and helps us put calcium into our bones and prevents fractures. And what's really interesting is you get a huge unwinding of your bone health in the first year after you go into menopause, and it continues to decline after that, but it's that first year that you really see a big decrease in your bone health. And that's why I always do with my patients a baseline bone density study, because if they're already osteopenic, so they're not quite osteoporosis, they're just grades in your bone, they're just grades in bone strength. I will always say, look, this is an extra imperative. And HRT is and it always has been approved as a treatment for osteoporosis, which is really interesting. However, the best idea is to try and prevent bone loss in the first place. So again, it's that imperative to use it earlier rather than later. So if, for example, you have your first fall and your first, what we call a fragility fracture, so a fracture that happens as a result of having weak bones, if you had that at sort of 68 or 69 and you went through menopause at 48, it would be quite difficult to consider estrogen as a treatment then. But if you had low bone density around the time of menopause and you're having symptoms, it's an additional imperative to select that treatment ahead of anything else to address that bone loss.
And while we're still, I guess, on HRT, I assume this is a form of it. So someone has asked, is there a limit on the amount of time that you should have Climara patches? But I assume that form.
Yeah. So A Clamara patch is a patch that is used for a week. So they're quite big, and people who do a lot of exercise don't always like them because they often start after a week peeling off, and they've been difficult to get. Having said all of which, any patches that are what we call that delivery across the skin is a much better delivery method than any oral hormone replacement therapy. So it's a good choice. And we used to say after the Women's Health Initiative, because the risk of breast cancer only started coming in at about 6.5 years, we used to say, that's it, at the 6.5 year mark, off your HRT no matter what. The problem is that the average length of hot flushes, if they only start after you've gone through menopause, is 7 years. If they start before you've gone through menopause, it's 11 years. So that 6-year thing is just simply ineffective. And then you've got between 1 in 10 and 1 in 20 women who are what we call the super flashes, and they flash for life. So now, and menopause experts say, you stay on it as long as you need to be on it. If you are getting more benefit from it, is there an increased risk? With that transdermal form of estrogen, so the type of estrogen that Clamara is, that is again probably a lower risk, particularly if you combine it with a lower risk progesterone. And certainly most experts would say, no, you do not need to get off it, particularly if the benefits outweigh the risk. I think the problem is that if it just comes to hot flushes, as long as you're on the Clamara or any other HRT, you won't know whether you're hot flushing. You won't know what would have happened had you come off it. And I always work collaboratively with my patients to say, hey, if you want to have a trial off it just to see what's going to happen, you've got to give it a month to 6 weeks off HRT to see what's going to happen. Go for it. I would only ever do that in winter though. I think in February we're all menopausal and we're all hot flushing, even the men. So it's just not a good time to road test that.
That's great, because that was one of the other questions, like how do I know when I need to stop? So you're just saying have a go, and if you need to go back on, go back on.
So there's no consensus by any menopause society about the right way to do it or the best time to do it, and it's really patient choice, and they should be working with their doctor, their prescriber. And I will always tell my patients, what's the worst thing that happens is you start hot flushing again, or you start getting down in the dumps again, or aches and pains are another common symptom that will happen as you come off it. Go back on it. It's not the end of the world.
Is there a difference between gel and patches?
So there are 2 types of gels on the market at the moment. So one comes in a sachet. That's not my favorite one, I'm going to be honest. It's one that you have to sort of put on the surface of your arm here, and I just find it doesn't absorb very well. It's quite slimy, and it's sort of you're skipping it up off the bathroom tiles and trying to put it back on, and then in winter you're standing around trying to wait for it to dry. There's a new gel that you put on the top of your arm and you squeeze it out. It's got alcohol in it, so it just absorbs really quickly together with moisturizers. So you just rub it down your arm. They're both forms of transdermal estrogen versus a patch, and there are 2 types of patches, the ones that you do twice a week and the ones that you do once a week. All have a place. So I normally say to my patients, if we're going to do a transdermal, women who are, let's say, single and don't want to have an awkward conversation with a new sexual partner about what's that on your chest, might prefer a gel, and that's completely reasonable. Some people get a very nasty skin reaction to the tape, so they just don't want to use patches. That's completely reasonable. Some people just can't be bothered to put a gel on every single time they have a shower. And that's completely reasonable. So I normally work collaboratively with my patients to lay out all the options and say which one works best for you, and I'll prescribe whatever you want. And if they really want a tablet, because some people just don't like the idea of anything on their skin, or they're very sensitive in their skin, then we can work with them around tablets too.
And I just want to, as we come to the end of this HRT section, because there's a lot of questions about other things as well, we'll try and get onto them. But I read in your book, you were saying that the prescribing of HRT is a bit of an art form to get the balance correct. And it's really important find a doctor who's willing to or able to go sort of through that process. And you've talked about the difficulty, even for you as someone who's interested in women's health specifically, finding information and knowing what the right thing to do is. So is your recommendation to not give up if you go to a doctor first and they don't understand, they don't know, or how important is it to find the right person?
So I find a lot of doctors do it really well, but if you have a doctor who is not good at this sort of prescribing and is still doing what they did 10 years ago, when there was really no information. I mean, the new gels have come out recently. There's a bit of a Kickstarter into, I think as women's empowerment grows as a movement, you're seeing drug companies move back into this space. But if you're finding that your doctor gives you something that just makes you feel worse, and you go back to your doctor and say, I don't know that this is working for me, and they go, well, that's it, you're off it. It's possible that you don't have the right doctor for you. And you know what? I am a loss on penises and testicles. It's just not my specialty area. I don't have a lot of personal experience, and I certainly don't have a lot of professional experience. They all look the same to me. So I'm not very good in that area. And I'd be the first one to go, look, you better take your dick elsewhere, because it's just not, excuse me, I've got a foul potty mouth. It's going to happen at some point. But yeah, so it's, that's an area I'm not particularly good at. I'm all over a vagina. That's just perfect. You know, show me that. I'm just very happy with that part of the body. We all have our special interests, and that's, I think if you are not getting anywhere, I would go to the Australian Menopause Society website and click on the Find a Doctor link, because we have all done a lot of extra training in menopause and we have a specific interest in it. And it is very unlikely that you will go wrong with somebody who's paying to be a member of that organisation.
Oh, we've had 2 questions about libido. So I'm putting that out there so that we can go into it, but I have one more.
So much to talk about.
I know, but I have one more about HRT. They're flowing in these questions, so it's great. They said that they went into early menopause. They've had very, very few sort of outward symptoms, the odd hot flash. Is there a reason to go on HRT other than to deal with particular symptoms that someone might be experiencing?
Yes, so great. These questions are fantastic and so important. Yes, so early menopause is a natural protector against breast cancer. So that's the good thing, right? Because you don't have a lot of estrogen in your body over a lifetime, and so you have a reduced risk of breast cancer, and that's where the benefits end. So you have a much higher lifetime risk of osteoporosis fracture, a much higher risk of heart disease, and a higher risk of stroke, as well as a higher risk of colorectal cancer, which is a very big and rising cancer killer in Australia, and a higher risk of dementia. Now, when you put all of those things together, plus the impact, we are going to talk about the impacts on our lady bits, our lady gardens, and our libido, you can write that part of your life off sometimes. And when you look at that, every menopause society in the world suggests that women go on HRT until the age of 50. So that's just to reset you to having the same cardiovascular risk and same bone risk and stroke risk and colorectal cancer risk as the rest of the population. That's regardless of your symptoms. Then after the age of 50, we'd be looking at it on a symptom-based prescription decision.
And just a really quick one, hopefully yes or no. Someone was prescribed a low-dose contraceptive to kind of deal with some of the menopause symptoms, and they want to know, do they need to take those 7 days of sugar pills and have the period, or can they just continually skip it?
Oh God, I always tell my patients to skip it. Who needs periods? Like, honestly, isn't that the best thing about menopause? Like, get rid of those. No, you don't need to take those. It's absolutely safe whether you are 12 or 45, that you can absolutely skip those. One of the things that happens around perimenopause is that you are still ovulating sporadically. So you do need contraception if you have a partner and you've not done some sort of long-acting contraception like a Mirena or a vasectomy, something like that. And it's a perfectly reasonable choice. An oral contraceptive pill is a much higher dose than the HRT, so we would normally switch you over to HRT around age 50. That's the norm.
Beautiful. All right. So now the two questions related to libido. So one said, is the drop in libido just something that happens when you get old, or is it older, or is it connected to menopause? And is there anything that we can do about it?
So yes, it is related to menopause, and actually the International Menopause Society late last year released its white paper around low libido in menopause. And there are probably a few things that combine to really trash your libido. So the first one is we know that vaginal symptoms, and they're mainly vaginal dryness, but it's also, you know, urine problems. And let's face it, nobody feels very sexy if their underpants smell like a pub urinal. It's not a lot of fun. So if you have a very dry vagina, sex is uncomfortable, that is just not a winner for anybody's libido. If your mood is low, that does not help your libido. If you are hot and sweaty and any other hot, sweaty body lying on top of you is just your worst nightmare, that is not good for the libido. So there's a few parts to it, but we also see huge reductions in your testosterone. And it took us a while to work out what role testosterone played in women. And in fact, it does seem that testosterone and low levels of testosterone, specifically in women who are postmenopausal and satisfy the criteria of hyposexual desire disorder. In fact, it just means super low libido, like, not even afterwards. Well, I didn't really want it, but that was actually quite good and I'd quite like to do it again. We're talking about, well, that's 5 minutes of my life I don't get back again. I don't want it. I would be very happy to never have it again. That kind of low libido does quite well when we, number one, treat your vagina, because that's really critical. If it hurts, you're not going to do it. And the second thing is we can give you testosterone. In this country, access to testosterone is quite difficult. It is often given by prescribers of bioidentical hormones, and they operate outside, I guess, standard medical practice and definitely outside the menopause societies. That's something that's fairly frowned upon by peak bodies who deal with menopause. We do normally more tailored prescribed testosterone, and I get all of my patients to get it from Perth. Believe it or not, you fax or email over your prescription and they send it to you in the mail, and that is done by a proper drug company, and that is going through by September this year. I believe it will be available in pharmacies in New South Wales and Victoria as well, but at the moment you have to mail the prescription to Perth.
And it seems to me that a lot of these treatments, the HRT treatments and the testosterone, they're all relatively expensive. Why is that?
Because menopausal women don't matter.
Right.
Because women over a certain age are irrelevant and not valued by society. And Jackie, we spoke about this during the week, but as a group, menopausal women are a very powerful consumer force. I mean, they outspend their premenopausal sisters on everything from handbags and shoes to makeup, skincare, fitness, health. To ignore that sector of the consumer world is pretty stupid. But, while everybody was arguing for free tampons and pads because women couldn't afford it, which I agree. I mean, we should definitely not be punished financially for being a woman. There's enough enough discrimination out there. But when it comes to menopause, it is absolutely like women do not matter at all.
It was, and so expensive to just be able to have access to all these treatments and these things to make our lives better. So another question came from someone who has had a hysterectomy and said suddenly taking weight off, like they're putting on weight and getting rid of it is becoming impossible when it used to be very easy. So let's talk about menopause a little bit and weight and why it happens and what we can do if there's anything.
Yeah, great question. So I remember my mum said to me, and she's very lovely and never says, "You're looking a bit fat, sweetheart. Do you want to just go on a diet?" She said to me, "You might want to just think about your weight a little bit before you hit menopause, because then it gets really, really tough," which is any woman knows absolutely the truth. The problem is we just don't have the real science to back that up. And in fact, there have been studies of metabolism of women who are postmenopausal, and in fact, the metabolism is no different to women who are perimenopausal. So here's what happens. If you are hot, and you've got aches and pains, you've got back pain and leg pain, you don't want to exercise. That's just terrible. If you are exhausted, lack of sleep is absolutely linked to weight gain for sure. And if you are seeking comfort food because you're a bit down in the dumps, that's pretty dreadful. But it seems to be more to do with those kind of related to menopause thing than the lack of estrogen per se. By the way, thanks for bringing up hysterectomy, because the hysterectomy is removal of your uterus and the fallopian tubes, but generally we leave in your ovaries, unless you're somebody like Angelina Jolie who had to have hers removed because of her ovarian cancer risk. Surgical menopause is horrible. You wouldn't wish it on anybody, because to go from full estrogen one day to zero estrogen the next is just quite traumatizing, and women feel dreadful, and most women who have it can't have estrogen for treatment, so it makes it much worse. But in theory, if you've just had a hysterectomy as a procedure to get rid of a problem in the uterus, which is what we normally do hysterectomy for, in theory, your ovaries should be operating around the same as they were before the hysterectomy, the day before the hysterectomy.
So, there's so many questions, I don't even know where to go. Someone asked, and I'm afraid, I'm sorry, my ignorance, I don't know what this is, but does menopause help with PCOS?
So that is polycystic ovarian syndrome. Wow, menopause and PCOS are my two passions in life. So polycystic ovarian syndrome, I think a lot of people think that it's just about the cysts on the ovaries, but it's actually so much more than that. And in fact, the cysts on the ovaries are caused by a very high insulin level. And I feel about this passionately because this is something that I have, and it's actually quite common in Ashkenazi Jewish women. So to all of my sisters who are sitting on the call who feel that how come when I eat like a packet of chips, I put on 15 packs of chips on my bum, and then my girlfriends have a packet of chips and she still looks like, you know, a Barbie doll. That's because your hormones are primed to just basically scavenge every calorie you ever have and turn it into fat. Lucky us. And it does disrupt the ovaries as well. So a long time after the ovaries have ceased to function, so you've gone through menopause, the insulin resistance that caused this problem in the first place is still there. And it will still prime us to put on weight, and it will still prime us to have a higher risk of diabetes and breast cancer and cardiovascular disease and stroke and dementia. It is something that will always be important to be taken seriously from a diet, from an exercise, and also from a medication perspective. You know, we use metformin to treat it. We use metformin to treat polycystic ovaries in younger women, and you use metformin to treat the underlying insulin resistance in older women as well. So it will hopefully stop heavy, painful, irregular periods, but it's not going to stop the other stuff. And it is it's a diagnosis that will kind of live with you forever.
So back to bones again. Someone's asked about the efficacy of taking calcium as a supplement, and another quick, kind of a bit tangential, we have the question of whether men who are having bone loss should look to estrogen as a...
So for men, estrogen won't help because it'll feminize them and they'll have low testosterone as a result, and they won't be very happy about that. Men with low testosterone feel dreadful. But in terms of calcium tablets, this is a really interesting one, because we know for sure that people who have what we call adequate calcium in their diet, so it's 3 serves of calcium a day for premenopausal women and 4 serves a day for postmenopausal women, have less bone fractures from osteoporosis. And we know that adequate calcium in the diet is really protective, not only against bone loss, but also for a whole lot of other conditions as well. The problem is, so do you then, if you take the calcium out of the milk because you don't like milk and dairy or whatever other reason you're intolerant to it, does it work as well? There is no evidence whatsoever for calcium tablets in terms of preventing osteoporosis fractures, quite sadly. And a couple of studies have linked calcium tablets to an increased risk of heart attack. Now, that doesn't mean that we've proven it. It just means that there are a couple of studies that have shown reasons to be concerned. My advice at this point, because I would take bone health very seriously, only because if you have a hip, if you have a Colles fracture, so that's a fracture around your wrist, that's annoying. If you have a hip fracture, you have a 45% chance of landing in a nursing home or dying within the next 12 months. It's a very serious condition, not to be dismissed lightly. You do not want to fracture your hip from osteoporosis. And you don't want to find out that you've got brittle bones with that being your first fracture. That's terrible. I would attempt, and I do personally attempt to get my calcium from my diet, and I am not taking a calcium tablet. I wouldn't take a calcium tablet just because there's a bit of a shadow hanging over A, its efficacy. So if there's no efficacy, well, I don't know why bother, and B, this potential risk of heart attack. And as a philosophy, my preference is always to get stuff out of food as opposed to pills. There's a lot we now know about the microbiome of the gut, about how whole foods impact on your health in a way that's far more powerful than just extracting individual ingredients and sticking them in a capsule in a factory surrounded by plastic is ever going to do.
So when we were speaking earlier, and from your book, there are all kinds of symptoms or things connected with menopause that I would never have put together. Brittle nails, itchy skin, your nose seeming bigger. Like, are you able to kind of, and also even you were talking about aches and pains, are you able to just kind of talk about a couple of those maybe lesser known connections? Yeah. And then I'd like to move on after that to sort of fatigue and some of the emotion. We've talked a lot about physical symptoms, and I'd like to talk a little bit about sort of emotional things as well.
So aches and pains is one that I'm fascinated by, because a lot of women who get into their 50s, and so menopause is happening around now, we get back pain, we get leg pain, and we put it down to I'm old, right? That's what they feel. But when there was the very large SWAN study, which was a very big study that just looked at menopause symptoms, in fact, aches and pains were more common than hot flushes.
Wow.
As menopause. And it's particularly common in women of Asian ethnicity. So that's not particularly relevant to our community, but we're having a more diverse community now. We're going to have more people from Indian and Asian backgrounds in our community, so it's one worth knowing. While very few women will want to go on HRT for their aches and pains, they just feel too embarrassed to go and say, I've got back pain, can you give me HRT? And very few doctors would go, oh, you've got back pain, that's got to be your menopause. But when I prescribe HRT for a combination of other symptoms, it is amazing how many women go, I'm back to running. I'm back to boot camp again. I'm able to do all the exercise that I can go 18 holes at golf instead of 9 holes, which I've been doing for the last couple of years, because they don't have the back pain and they don't have the leg pain. So I think that is a fascinating one that who'd have known, and one that I always have my radar. I always ask about it in consultations. The itchy skin is a really interesting one. So I can tell you all of the things that happen at a cellular level to the skin as your skin starts to age, and there's certain parts of it that start to get thinner, and you get more of what we call transepidermal water loss. So anybody who's like me, beauty obsessed, not because it's a commercial thing. I have a skincare company. I've got no tickets on myself, but I'm very interested in skin, and we're all trying to hold back transepidermal water loss. That happens more with menopause, and for sure you're going to have itchier, drier skin, and I think most people who've gone through menopause know that. You can see it in your skin. It's pretty noticeable, and itch is one of the symptoms that you'll have if you are prone to eczema-y, dermatitis-y kind of things as well, and there are treatments for that, and often it's not the sort of symptom that we give you HRT for, but we'd probably it's just something that might help if we go on HRT as well. In terms of the way the face changes, there are actually fat pads that sort of sit in different places, and bones actually start to disappear, and these little lovely cheeks start to fall south, and so you get these lovely jowly bits, and you look a bit haggard. Yeah, they all go here. What's that? I want that. And then you sort of look a bit more haggard here, and your nose just appears to be bigger. Your eyes sort of sink a little bit. because your bone is being eaten away, thanks osteoporosis and aging, but that your nose will definitely start to look bigger. It's not growing, it's just the other structures around it are shrinking, and no one's a big fan. You can go to a cosmetic doctor, who is definitely not me. That is not my interest at all, but you can get injected sort of stuff into your cheeks. I am terrified of, I've never had any of that Botox or fillers or, I don't know, threading and needling and all that, laser and dermabrasion. I don't do any of that because I'm terrified of it. But I think that if that's your thing, you have my full support, sister. Go for it.
One of the interesting revelations that came to me from your book was about skincare, actually. And I wanted to, I know you have a company, but the reason for the company was, you know, is I think really important. But I had always sort of read skincare claims from skincare companies, and when they talk about science, I kind of just dismissed it all as sales pitch. But there is an actual science to skincare, and also some of the things that people are concerned about connected with menopause and their skin. Are you able to just talk a little bit about that?
Yeah, so for anyone who doesn't know, who I haven't bragged about, this is my brand, ESK, which is Evidence Skin. So basically, I think, you know, I've been doing Sunrise since 2006, so a long time now. And we'd often do segments on what really works in anti-aging skincare. And I just literally go through the studies and go, you need L-ascorbic acid and you need retinaldehyde, which is, you know, L-ascorbic acid is the only form of vitamin C that works. And retinaldehyde is the most effective form of vitamin A. And I'd go through all the studies, and they're actually loads of studies that you can go onto the National Library of Medicine, which is run by the National Institutes of Health in the United States, and it's made public for everybody, every study that has ever been published. And you can see for yourself what actually works. And I would go via ingredient to talk about it on TV, and then I'd get like 300 emails of people going, but what should I buy? And I go, okay, better go and have a look. And I would look for the ingredients for which there was evidence, and I couldn't find them in any of the products. And I really spent hours in David Jones and Maya. I looked online. I really have not been able to find anything, and I couldn't work out why. I now know why. It's not that easy to formulate with evidence-based ingredients. But one day I was sort of talking about it to Daniel, to my husband, and I said, it's just crazy that, you know, there's just nothing evidence-based on the market. And there was starting to be a little bit more, I think, as people started to cotton on to the fact that we don't just want a pot of cream that smells lovely. We actually want things that are going to change the structure and the function of the skin. But we just decided to go and make it. And initially, for the first sort of 4 or 5 years, we just partnered with plastic surgeons, dermatologists, and made their own skincare ranges for them. And we've got them in Canada and Malaysia and Hong Kong and all over Australia, obviously. And then we launched our own brand, I guess, leveraging the knowledge and experience we had in running the first company. We launched our own in 2017. Yeah, and so it's going super well. And so that's my particular interest in what works in aging, pigmentation. I've always had really dreadful skin. I was a complete pizza face as a kid. I literally slipped seamlessly from acne into rosacea. Yay, lucky me. So I'm getting maskne. Is anybody else getting this mask breakout and redness, and my cheeks burn, and it's just fabulous. So problem skin has always been an issue for me. And when you're on TV, you get this thick pancake put on top of you, and you're just like, bleh. Your skin feels and looks horrible. So I had high incentive to not go on TV with big red welts all over my chin and not very flushed cheeks. And I wanted to get rid of my pigmentation. So that's what I've done.
So what's rosacea as opposed to acne? Maybe.
Super common condition amongst, so it's really white women in their 40s and 50s mainly who get it, although my son has it, and he's had it since he went from acne to rosacea very young. So they're different. You do get pimples, but they move from your T-zones, which we all remember from our 13 and 14. In my case, it was up to my 40s. It moves from your T-zones to kind of more around your cheeks and around your nose instead, and you get a lot of redness, and you're very, very, very sensitive in your skin. So there are 2 types mainly: the pustular rosacea, so you get the lots of pimples, but in this sort of band across your face more than down here compared to acne. And then you get the flushing rosacea. I'm lucky enough to have both. Well done me. But that's where you get very flushed, and you often know your triggers. Often you go out into the sunshine and the sun hits your face and you turn into a beetroot. Or you have a curry and people are going, you okay? Because you look really red. In my case, it's one glass of wine, which is a tragedy because I really, really like wine, and I'm not going to give up now, but you know, that is going to be the cost.
Let's talk, move a little bit now. Oh, there's one more question about vitamins. So they asked, what vitamin supplements would you recommend a generally healthy menopausal woman to take on a daily, if anything?
So with our knowledge of the microbiome of the gut and how whole foods interact with our bodies, and also the lack of evidence to support individual vitamins for really any condition. And there was a very large study called the Iowa Women's Health Study that came out in the early 2000s that showed that despite the fact that women who set health as a high priority and a high value in their life being more likely to engage with supplements, so that they were women who are less likely to smoke, drink, binge on a packet of Tim Tams for dinner, these women died admittedly only 3 months earlier, the women who took supplements, than the women who didn't take supplements, which is a counterintuitive kind of thing. I don't take supplements. I try to just get my vitamins from my food bowl. I think the one that's been really interesting is vitamin D. So vitamin D, to call it a vitamin is probably a bit of a stretch. It's actually it comes into our skin via sunlight. It is in some foods. Some seafoods and dairy have vitamin D. Mostly it's just fortified. It's just chucked in as a fortification into things like bread and breakfast cereals, that sort of thing. But it's also integral for bone health. Our problem is that outside the nursing home, frail elderly community, we have no evidence that vitamin D supplements do anything to help any of us with our health. And that's a really big problem because we know that vitamin D deficiency is linked to everything from breast cancer and low immune system, worse prognosis in COVID, that's just come out, more heart disease, weight gain, so many things, but we don't have any evidence that taking the supplement will actually help that. And it possibly is that vitamin D is more a biomarker of your going outside. And we know that people who stay indoors all the time and just work or never do any exercise outdoor, that's not particularly healthy. And is it the vitamin D that's the problem, so we're taking a supplement, when in fact what we should be doing is just going for a walk?
So people like me who are very fair and wear sunscreen every day, even if we go out in the sun, does that have a...
Yeah, so I'm the same as you. I think I should have been living in a peat bog in Scotland for my entire life. And I always feel like I'm getting skin cancer if I'm out in the sun for 5 minutes. Luckily for us, we absorb much more vitamin D from the UVB spectrum than do our darker skin sisters. So if you remember, UVA is for aging, UVB is for burning and skin cancer. Most, when you look at the SPF of a product, that only refers to protection from UVB rays. It says nothing about the UVA protection. So you can have an SPF 50 and not actually have particularly good aging protection. So there's the Skin Cancer Foundation or the Cancer Society will be all about the SPF because they want to prevent melanomas, which we all do. But if you don't want to age, you need broad spectrum and high UVA filters as well. The vitamin D absorption sits in the UVB panel, so that an SPF 50 is definitely going to prevent you absorbing too much vitamin D. However, the formula is what you need per day is your burn time divided by 3 per day. So for example, if you and I burn in 5 minutes, which yes we do, then we only need a third of 5 a day to get adequate vitamin D. Whereas our darker skin sisters, who I pay to have skin that looks like that dark, I'll never get there, they will need to stay in the sun for possibly an hour to get the same amount of vitamin D. So we've actually done better.
Oh, that's really interesting. Hey, someone just asked a question asked if we could go back to weight gain just for a moment. They said that weight seems to go on in different places than it used to. So is that typical? They were saying mainly around their middle, just below their rib cage. Is that a typical thing? And Then to get, I guess, onto the next topic, they've also asked about snoring. They said they're snoring a lot more. Is that connected as well? So let's do weight around, moving around.
So estrogen will determine that your weight will go around your hips and your bum and on your boobs, which we probably like. And that fat sits under our skin. We call that subcutaneous fat. And believe it or not, that protects us from cardiovascular disease. So you might not like the look of it, and you might want a thigh gap. I really hope you don't, but if you do, there is no health benefit from being skinny on your bum. Unfortunately, once estrogen is no longer there, but your ovaries are still producing a little bit of testosterone, that determines that your fat will go around the middle. And the problem with that fat is that it doesn't sit, or a little bit of it sits around the skin and under the skin and wobbles. Thank you, awesome. But the rest of it sits around your organs. And that means that if we did an ultrasound of your liver, it would be full of fat, and so is your pancreas. And as a rule, that is unhelpful in terms of your cardiovascular risk, cancer risk, and diabetes risk. It's harder to shift that fat, the fat that goes around your middle, but it is, for health reasons, really, really important to get rid of that one.
Wow. And what about sleep and fatigue?
I didn't mention about sleep apnea too, because that lady had asked about, was a lady, I'm guessing, but yeah. So when you snore, often you snore because your upper airways collapse, and that's particularly a big thing when you put on weight. But if you are having moments of apnea, so your snoring gets louder and louder and louder and stops, and then you do a big gasp for air, and then it all starts again, the crescendo, that is sleep apnea, and that's linked to a number of problems from car accidents to heart disease and blood pressure, and it's really important to get that diagnosed. Is it related? It definitely goes up. We definitely see it increasing around menopause, but that's probably because of the weight gain.
And what about sleep and fatigue in general with menopause? Is that related?
It definitely goes up. So there are a few things just to keep in mind. 1 in 6 women in Australia will experience a thyroid problem, and menopause is a key time when your thyroid starts to tank and you'll feel very, very tired. So it's always worth having a blood test, because you won't know until you've had a blood test. And that tends to run in families. So if your mum had a thyroid problem and you all of a sudden at 55 start to feel really tired, like we're not just talking about, gee, I'm really tired at the end of the day. We're talking about, I don't even, think I can get through lunchtime without a sleep, then you probably should have a blood test just to make sure. If you are in perimenopause and your periods have gone to Armageddon and you are literally bleeding for Australia, you will probably have very low iron levels, and that will also make you very, very tired. If you are hot flushing and having night sweats and you're not sleeping at night, it is probably very unlikely that you will feel full of beans the next day. And we know that you can acquire a sleep debt. We now know that from studies that sleeping badly on Tuesday night, if you then sleep, only for 7 hours on Wednesday night and then only for 6 hours on Thursday night, by the end of the week, you have a massive sleep debt. And after a couple of months, well, it's just really difficult. It's very hard to not feel tired. And that's, again, an additional imperative for taking menopause symptoms seriously, because all these tired women out there are not meeting their true potential.
Yeah. So someone asked then if HRT has any impact on thyroid, or are they completely separate? And would you take HRT? Does HRT help with the weight gain question from before?
So yes, HRT does seem to help with weight gain. So we have that from studies. Again, it doesn't seem to be the hormone levels, but relieving your hot flushes, making you feel less emotional and getting rid of some of your aches and pains so that you can eat better, sleep better, and do more exercise seems to be the missing link there. Even though we do get thyroid changes around big swings of hormones, so postnatal, after you've given birth, during pregnancy and around menopause are big times for the thyroid to pack it in. No, HRT won't protect your thyroid at all. They do seem to be quite separate, and we're not really sure why. But you wouldn't take HRT to sort of keep your thyroid functioning well, because you might be one of the 5 in 6 women who never runs into a problem with it. So it's just not a reason to go on HRT, unless you're going on HRT for your hot flushes and your aches and pains and your mood problems, and then, we'll throw that in for free as well.
Someone's asked if melatonin will help with sleep for perimenopause. Or...
Yes. So melatonin is your natural sleep hormone. It actually interestingly, you start to see it peak in the brain about 2 hours before sleep. This is very interesting. So if you're going to have a really good sleep pattern, you want to be turning your melatonin on not when you land in bed, but a good hour or two before. It seems to prime the brain for sleep, and it's naturally turned on by darkness and turned off by light. And the stronger the light, the more hard it's turned off. So if you, in COVID, I think one of the problems that's happened is that, you know, people have got out of bed, maybe turned on a light, but even the strongest light inside is nothing like weak sunlight outside. So it's very important to go stand outside and get some melatonin on your face to shut it down if you want to get your sleep back in order. The evidence for melatonin is mixed for women of menopause age, even though we know melatonin levels are lower in perimenopause and menopause. Having said all of which, I do like it for menopausal women, and I'll often use it because it's just supplementing a natural hormone, and it's not actually one of the more horrible medications that we really don't want to put you on for sleep, which just make you really stoned and knock you out. I think the most important thing is to get your bedtime routine really sorted and to start to chill out in the hour or so before sleep. And that involves dimming the lights, getting off your screens. We are all spending way too much time on our phones and iPads. And even though, yes, it is a time to switch off and relax, we've really got to break that habit. If you're a bad sleeper, I mean, some people sleep like a train, doesn't matter, and that's fine. But if you have a problem with sleep, then I would just be getting off your screen. And no, don't bother with orange glasses. There's just not a lot of evidence for them. But yes, you can get melatonin supplements from your doctor, and they're easily available.
So I'd like to shift a little bit to some of the emotional sort of things that happen during menopause. You know, I've heard about increases in anxiety and depression and anger, kind of an inability to kind of cope with things that used to not irritate you at all, but now kind of send you off the scale. Are all of those things connected, and what can we do about them?
So interestingly, perimenopause is your peak time for anxiety. So this is in the lead up to menopause, where you've got your hormones swinging wildly, and you actually get 1 in 3 women end up with a major mental health complaint. So whether it's anxiety or depression, that is a very big number, because if you have a look at across the board, definitely women get more depression and anxiety than men. But after menopause, that tends to even out quite a lot, in fact. And in fact, after menopause, there is less depression. But it seems to be at that time of big hormone swings that is a really big problem. Are the hot flushes and the insomnia contributing? Absolutely, it's definitely a problem. Your changing body image is definitely a problem, but there's definitely something hormonal going on, and HRT will often work to actually help that problem. And it just does. Mental health is complex. I think it's really interesting, if you look at the studies, what gives you the worst prognosis during perimenopause, and there's a whole lot of studies about, you know, what gives you a really poor prognosis. There are 3 things that stand out. One is having poor health yourself, or very poor health in a partner or a close friend or family member. The second is being a carer of your parents. And I think all of us are in the sandwich generation, which I think we've talked about a lot, Jackie, but this is, particularly at a time of COVID, we are so worried about our parents, and we are feeling increasingly responsible to connect them to the world and do their shopping for them. That's very interesting. And the other big one is having a change of job or losing your job at this time. Now, again, we are in the middle of job Armageddon with COVID, and it does make me think that, are we about to see that 1 in 3 statistic for perimenopausal women getting a major mental health issue just upping to 1 in 2? Because those factors are here. We are all worried about our parents, and we are all, you know, job insecure at the moment. So I think it's just something to think about with our sisters, to make sure that everyone is okay, and to check in.
And I think that we've focused so much during this pandemic, as we need to, on the physical, effects and things of COVID, but the mental health toll is enormous. And I think we're just starting to wake up to the toll that is taking on so many parts of the community, but definitely for menopausal and menopausal women as well, and for those reasons. So I think it's really important that we find ways to address that, I guess.
But I think that the community does that. I mean, it's a very interesting community, the Emanuel community, but we do know that connectedness, a feeling of connectedness, is critical for resilience. And resilience is very protective against major mental health disorders. And I think that being a member, like even just joining up to this webinar and connecting with your sisters through this community is an act of great connectedness, and it's a great way that the shul can help bolster resilience in its community members and really help protect against some of these really difficult experiences that we're having right now.
So in terms of people who, for whatever reason, can't or don't want to take HRT because it's not for everyone, are there alternatives that are efficacious or that they should look at?
Yeah. So there have been more studies done in hot flushes than anything else. So in terms of the mental health related to HRT, to menopause, there haven't been as many studies. There have been some, for example, of St. John's wort, which the studies in all complementary therapies tend to be small, because to stage a large, what we would call a level 1 evidence trial, requires tens, if not hundreds of thousands of dollars, if not millions. And that's just something nobody's going to pay for a generic product where there's no financial gain for the sponsor of the trial. So we have these very small studies that have been done for various complementary therapies. But there are things that are worth trying, and there are some that are worth really steering clear of. And it can be really hard to know which one. When I wrote my book, I created a Gwyneth scale where I related the number of Gwyneths to how completely crazy a particular intervention was, from 0 Gwyneths being, yeah, that's probably not a bad idea to give that one a shot, to 3 Gwyneths, do not try this at home, this is just a disaster. And there are some that are like, you know, little studies, admittedly, but the things like pine bark, which seem to be reasonably effective for reducing hot flushes. The thing that is very interesting with the complementary therapies was that across the board in all of these studies, the placebo effect was up to 70% for hot flushes, which just shows the power of the mind, really. But it does sort of, then there's a lot of doctors who will go, that's all a placebo, but who cares? If it's a placebo and it works for you, I don't care, as long as there's no side effects, that doesn't matter. With women who have had breast cancer or who carry the BRCA gene, so it's not technically a contraindication, but most oncologists would recommend that the BRCA gene makes you more prone to estrogen receptor positive breast cancer. So that's 50% of all breast cancers are estrogen receptor positive, plus ovarian cancer, which is estrogen receptor positive. So to put estrogen into the body is a riskier strategy. And for anyone who's had an estrogen receptor positive cancer, the answer is no. We've got other things. So HRT is 96% effective at getting rid of hot flushes, but we do have reasonably good results for antidepressants. I think some women hear antidepressant and go, well, I'm not depressed, I'm not having that. And there's, again, a little bit of stigma attached to that, which is a shame. As I tell them, this is not at an antidepressant level. In fact, there's a specially formulated low dose that would do nothing for depression, dose of venlafaxine, which is one of the common antidepressants that's used quite effectively. But if you don't like that, I've had quite a lot of good results from oxybutynin, which is a medication that's developed initially for not good bladder control, which that's just my issue. I don't want to overshare, but like, not happy with my bladder, too many kids, whatever. But it was developed for that, and as a side effect was found to sort of, like, we're talking, it's 80% effective at getting rid of hot flushes. Like, that's the one that I always put my cancer patients on, is the oxybutynin, because I think it's just, it throws in bladder control for the same price, which I kind of like. Then we've got some, we've got really good results for tibolone, which is a progesterone-only HRT that doesn't have any estrogen in it, but it actually seems to do quite well for controlling hot flushes. I'm careful with tibolone for anyone who's had a history of mental health issues, because it can actually set your mental health on fire and make you feel like you're going crazy. I would talk about this with your doctor, particularly if you have had breast cancer. Breast cancer oncologists get it, because when they put any woman on tamoxifen or Arimidex or one of the medications that's going to make you medically menopausal, they know that you're going to get hot flushes, and they're all over treating it. So if you've got an oncologist, talk about it with them, because they'll help you. If not, I would go and talk to a doctor with interest in menopause who can run through your various options that will hopefully kill as many birds with one stone as possible, because it's very rarely just hot flushes, isn't it? That would be so easy.
So speaking of treatments that were developed for one thing and found great use in another, I wanted to talk a little bit. We had a question about hair loss and hair growth. So hair grows where we don't want it to. It falls out of our heads. What can we do? Is there anything we can do?
Yeah, so hair loss is it's not easy, because by the time you work out that you've lost hair, you've probably lost at least 40% of your hair, because until then you're not going to know about it. So we do this ponytail test. So how many wraps of the elastic band you need to wrap up your ponytail, and if you're needing an extra wrap of your elastic band to put your hair into a ponytail, you've probably lost about 40% of your hair. So it happens late. Restoring hair is difficult. We do have Minoxidil, which is, I think, made famous by Shane Warne. So there's a medication that you can get at 2% level and a 5% level, and you can rub it into your hair. It's twice a day. It seems to more prevent hair falling out, and then the little hairs that do grow just a bit slow, right? But they will grow, and instead of shedding 100 and gaining 100, which is what we're meant to do, ever grow 100, you just grow them and you don't shed them. That's the idea behind Minoxidil, but it's slow, and a lot of people get a lot of irritation on their scalp and can't use it. Plus, I find that for a lot of my patients, if they don't see a benefit inside kind of 8 weeks, they're like, they're out. And you've got to be really patient with Minoxidil. Otherwise, we're looking at hair transplanting, which is get ready to invade your super. I don't know, sell a house. It's not cheap, it's not comfortable, and they literally harvest hairs from places in your head that you don't need them, like back here, and then put them on top of your head. There are trichologists who do this. It's just like, that's slow and it's really expensive. So my advice for all of my patients, look, if you're losing your hair because you've got a thyroid problem, great, let's diagnose that and treat it. If you're losing hair because you've got an iron problem, let's diagnose it and let's treat it. But if you've got a familial alopecia, so in other words, your hair falls out because everybody in the family's hair falls out, we are limited with what we can do hand on heart. I wish we could do more, but there's not that much we can do. As for the hairs on your chin, they're grey, so they're not going to go really well with laser. So if you can find somebody who's got an old electrolysis machine, they will be able to help you. Electrolysis works beautifully. And there is actually a cream that you can, a hair retarding cream that is actually, Jenny, listen, Jackie, you think you've spent a lot on HRT and testosterone. Wait till we pull out the Vaniqua, which is the cream that goes on your chin to stop their chin hairs growing. You basically need a third job, a fifth job, whatever, to support it. But you know what? It's there. You can have it. A few of my patients go, you know what? Tweezers are cheap. I'll just do that because deal with it.
The problem, I think, with the tweezers is that your eyesight is going at the same time as the chin hairs are growing, so you don't see them.
And the thing is, you get really oblivious to what's going on. So you just go, I've just got an amazing view of my chin while I'm driving, you know, and I've got this fabulous mirror, and the light is just so, and oh, oops, there's all these guys looking into my car as I'm getting my tweezers out and pulling out my chin hairs. Yes, it's a very personal moment that you just need to share sometimes.
I'm wondering if they're going to have cameras for that, you know, like they've got the mobile phone cameras, because they're going to have cameras for plucking. You can't do it at the lights anymore.
They need a new law, the anti-plucking law.
Now, someone said their friend is 60. She's 5 years post-menopause. Is it too late to start HRT for the benefits that it could potentially give?
No. So we generally say 6.5 years after you have gone into menopause. So this woman obviously had a late menopause at 55. If it only happened sort of 5 years ago, that's fine. And no, it's not too late. But I think if it's just for the health benefits, as in I want to look and feel younger, that old school 80s and 90s kind of elixir of youth thing that you're after, you might struggle to find a doctor who's going to prescribe it for you unless you have got a bone density that shows that you're already in the osteoporosis range at that very early age, because that's really quite scary, and we'd want to really boost her bone density fairly quickly if she already had osteoporosis at that age. So I think that's just one to negotiate with the doctor. But she's having hot flushes for sure. I mean, go on it tomorrow.
Okay, brilliant. So in your book, you wrote a chapter for partners, and I want to know what motivated that and what we can do perhaps to have this conversation be a little bit broader.
Yeah, so I did this in collaboration with a whole lot of experts around the world, actually, this project. And Dr. Fiona Jane works out of Melbourne. She works at the Jean Hales Foundation that does a lot of the research into this space. And she actually said to me, have you written a chapter for, pass this to your partner? And I thought, gosh, I absolutely need to do this, because a lot of guys are, they're just going to get their bottom handed to them for some of the comments that they're making, and I completely get it. So, and I think they needed to have it explained to them, kind of the "it's not you, it's me" conversation, but from their doctor. And I think particularly around low libido, vaginal issues, and the fact that, if your partner has prostate cancer and he can't get it up anymore and he doesn't want to have sex anyway, then everybody's happy. And do you really need to turn your vagina back on? Oh, if everyone's happy, that's fine. But if there is a huge conflict within the relationship because he really wants to have sex and you have fond memories of sex but don't actually enjoy it anymore, it might be in everybody's interest to get that fixed. And then and so then it would definitely be worth having him involved. But I think there are so many men who just go, you need help. You need a therapist, you need to go see a doctor, just go get yourself some help. And they don't have the lovely collaborative response to healthcare that I think men should have. And they are always welcome in our surgeries. They often are not frequent flyers, and they come in once a year and just go, what do you mean my blood pressure's up? It's never been up before. No, because you've never been here before. That's right. If you're going to make your wife go to the doctor, why don't you go with her and get your health checked at the same time? And then if you, instead of going, you're fat, why don't you get your own body mass index tested? Because I guess you're probably fat too. So why doesn't everybody go on a diet together? We're all going to strengthen our bones, and we're all going to get our blood pressure sorted, and we're all going to be happier. And it's a win-win. We're going to do it as a team. There's
a great comment here that says, I asked my husband yesterday if I was being more bitchy lately, and he gave me a panicked look. So I think that's right. What is the right answer to that question? There probably isn't one. So thank you.
Love it.
Someone asks, is Minoxidil dangerous? I don't know what that is.
That was the hair loss thing that we were talking about. Oh. No, look, it can certainly irritate, and some girls get a lot of scalp dermatitis from it, and they can't really use it, and so then they stop using it. But otherwise, no, if it works for you, you can keep going. It's fine.
Fantastic. All right, we're on the home stretch. So if people have questions, quickly type them now, because it will be a bit late to be able to do that later. So I guess I wanted to just say, I think in your book that one of the great things is that you look at so many alternatives. Like, you look at all the things that people have kind of raised or suggested as possible options. And I'm just wondering how hard it was to find all of that information. And
so I guess I had stuff that has come to me from my patients, and I was filming Medicine on Myth at the time, and we had more applications for menopause cures than anything else, which was really pretty interesting. It just shows how little there is out there for women. I never take the attitude of when I have a patient come to me that it's all about me. It is always really essential that the patient is the pilot, and that I'm a very able co-pilot for them. And my role I see as being able to provide some information and then to be that person that they bounce stuff off if they want some more information. So it will always be up to my patients what they do. I mean, I might look at them and go, I wouldn't handle that hot flush. No, I wouldn't put up with that, but that's not up to me. If they don't mind it, then that's completely up to them. I feel sorry for somebody if they think it's unbearable, but are too scared to take what is a very effective treatment. I think that's really sad, and I'd like to do what I can to help them. But when it came to collecting all of the various complementary and alternative therapies and everything we go in this book through, everything from yoga, weight loss, every complementary therapy, Chinese medicine, I'm very lucky that I'm a member of so many of the international menopause societies, and a lot of them have collated a lot of this data, and they've got researchers, and then they publish it for their members. And I spoke to every menopause expert pretty much in the world, and got their take on it. And the take that I got from really everybody was, stick with anything that you're going to try for 6 weeks. And if something's not working after 6 weeks, bail. And that happens whether it's HRT or a conventional medication or Yohimbi or, or Maca. It doesn't really matter. If after 6 weeks you're not going to find any benefit from it, you're not going to start after 6 weeks. So move on. That was a really good message I got.
I think that was, for me, the best part of this book was that I went looking before to try and find information, and it was so hard to find, and everything was if I found things, they were studies, but you could read the medical study, but for someone like me, that is not helpful. I want the bottom line. I want you to tell me, does it work? Is it safe? That's what I want to know. And so it was so wonderful to have it all in one place, and so easily digestible, I guess, in that way. And I think that's a real gift that you have, and it's not preachy. I think sometimes we get very finger wagging, preachy kind of things, and that you didn't have that at all. So we have 2 more questions. One is about Sporactin tablets for hair loss.
Yeah. So Sporactin is actually technically a diuretic, and it's what we call a potassium-sparing diuretic, isn't it? As opposed to a loop diuretic, it doesn't really matter. But one of its side effects is that it sits on androgen receptors, so testosterone receptors in many parts of the body, and blocks it. So they're sitting in there and can't allow the testosterone to get onto the hair follicle. And so it seems to be a testosterone blocker when it comes to hair, so that you don't shed as many hairs. So it'll be a slow one with Sporactin, because it can't make hair grow. All it can do is stop excess hair falling out because of the testosterone. Girls who've got polycystic ovaries have often already been on Sporactin, and it will also help slim your ankles because it'll help you shed some fluid at the same time. So some people get very low blood pressure on it and they can't take it, and some people who have a very high potassium diet, so that's anything fresh, fruit and vegetable, might struggle, and they just need to watch their potassium. But otherwise, it's something that anybody can do with a prescription.
Yeah. One last question, I think. Someone said, I tried a Climera patch and was very nauseous and couldn't stand it. Is there anything else, or should she persist and it will pass?
So some people are very sensitive to estrogen, because all there is in Climera is estrogen. There's nothing else in there. And some people, you get morning sickness, and we all know some people are very sick on the pill and they just can't tolerate it. So I would say that you probably need to go down a dose. And what I probably would do, because Climera is designed to have a slow release every day of estrogen, and there are different size patches from 37.5 micrograms up to 100 micrograms. So there's sort of quite a variation in the doses. You could try going down to a lower patch, and it also might be that there's something about your skin where it's releasing all of the estrogen very early in the patch. So you can try going onto a twice weekly patch, or even one of the gels that we talked about earlier, where you're just giving yourself enough for one day, and perhaps with a lower dose, that could be what I would suggest for you. You do tend to get over it after a while.
Thank you so much, Ginny. I can't even begin. We've had a few comments already just saying how informative and how amazing this has been, and we still have a million questions, but I hope that people will find their answers either with their GPs or from reading your book, or both those things, or going online, whatever it is that that people do. But you're amazing and remarkable, and we're so grateful that you've taken the time, especially now. I know things are crazy for you at the moment, so really, really grateful. And just to let everyone know that the book, you can buy it in a bookstore or online, but ebook also is a way to read it. And Ginny has also done an audiobook where she is the voice of the book, so it can be like having Ginny there with you, answering your questions and guiding you along. And I encourage us all to talk. I think that even amongst women, we seem not to talk to each other about menopause, and especially about the things like loss of libido and, you know, all those other things that are going on. And I think the more we speak, the more we can find a real sisterhood together and realize that we're not the only one. And like so many things, I think it's really beautiful to have people walk beside us on this journey, and our partners and other people in our lives as well. So talk about the M word, everyone, get out there. And we are so grateful and thankful to you, Ginny. Thank you so much for your time and for your wisdom and for just being the amazing human being that you are. So we are grateful for your gift and your presence and everything today. And thank you to everyone who joined us. We're really grateful that for your questions and for being part of our conversation and our discussion. So thank you, everybody. And we will contact the people who have won the books, and we will get them to you we'll send you an email, and then we will get the books to you. So thanks, everybody, so very, very much for joining.
Thanks all.